Hello, I am Tim Lee. Today I would like to talk about how to advance automated computer-aided diagnosis system for melanoma detection. This is the outline of my talk. I will first give a short introduction and then I will discuss 3 points that I think could advance automated computer diagnosis system for melanoma detection, so that the method could be accepted more easily into clinical practice. The 3 main points are explainable results, clinical knowledge, and extra information. In my opinion, the most influential work to the doctors in this area is a Nature paper published in 2017. The paper reports an AI system for classifying over 2,000 skin diseases organized in a hierarchical structure as shown here at the left-hand side of the slide. The structure consists of 3 top-level disease classes, such as non-neoplastic, malignant, and benign. The second level of malignant classes consists of cutaneous lymphoma, dermal, epidermal, and melanoma, while the second level of benign consists of melanocytic, epidermal, and dermal, etc. and etc. A database of 130,000 skin images were trained by a Google Inception V3 convolutional neural network. Examples of some of the images in the database are shown in the bottom right. Many of the images in the database are from the ISEE Dermoscopic Archive. The Nature paper reports 3 main experiments. The first one differentiates 65 carcinomas, which are basal cell carcinoma and squamous cell carcinoma, against 70 seborrheic keratosis, and compare the classification result with 25 dermatologists. The sensitivity and specificity of dermatologists are plotted as red dots in the leftmost panel of figure A. The green point averages all dermatologist results. The CNN result are shown using a ROC curve which is above most of the red dots and the green point. And the area under the curve is 0.96. It means that the CNN outperforms most of the dermatologists and their average. The second experiment differentiates 33 melanomas and 97 benign nevi using clinical images. The results are shown in the middle panel of figure A. Again, the CNN achieved an area under the ROC curve of 0.94, which outperforms most of the 22 dermatologists in this experiment and their average. Finally, the rightmost panel of figure A shows the comparison of 21 dermatologists and CNN on differentiating 71 melanomas and 40 nevi using dermoscopic images. The area under the curve was 0.91 and again outperformed most of the 21 dermatologists and their average. The paper goes on and predicts that 6.3 billion smartphone subscriptions will exist by the year 2021 and can therefore potentially provide low-cost universal access to vital diagnostic care. I have been working in the skin imaging area for over 25 years. I have never seen so much reactions from dermatologists on a paper. Many of them are convinced that AI will take over melanoma and skin cancer diagnosis in the future. Although this paper report only two class classification results in a somewhat artificial setting. Since then, there have been so much progress in the field. The ISEE is one of the main organizations to push the advancement. The exciting yearly challenge has been increasing the number of training images from about 1,500 in 2016 to over 33,000 this year. And the difficulty of the challenging task has been increased too. For example, the last year challenge task was to perform a 9-class classification. This is a very difficult classification problem, but the top leaders achieve a good balanced multi-class accuracy. When you check out the details of the top leader, you will see a much more impressive results. All areas under the ROC curve was way above 0.9, except for the unknown class. The clinicians start to believe the experiments are close to a real-life situation. But there is one thing in the back of the mind. The current AI technique is a black box. It does not explain how the results are generated. Many doctors concerned about the black box nature of the current technique. Could we make the results explainable while we improve the detection accuracy? It is known that filtering operations can be observed by visualizing the filters. For example, the Gabor filter banks, shown here, can capture general texture features with a set of parallel bands. In one of our papers, we use a stack SPAR autoencoder to detect and localize cutaneous vasculature from skin images. Example of the image are shown here. They have fine vessels with different morphology. The top image shows linear vessels with different shapes, while the bottom image shows many dotted vessels. The autoencoder or the SSAE will try to learn the key features from these images so that the features can be used to detect blood vessels. Here we examine the filtering features of the system. The SSAE network was initialized by a fine-tuned pre-trained AlexNet. Here we visualize a small set of the pre-trained and fine-tuned features. Some of them appears to have a shape of the basic texture features similar to the Gabor filter banks, showing parallel structures, while many others look like natural features related to the ImageNet image, such as animals and trees. But none of these features are associated with blood vessels. On the other hand, the final features obtained by the SSAE show different shape and patterns of red color and pigmentation, dotted pattern, curves, linear and combined patterns at different orientation and width with texture profiles. Visualizing these features enhance our belief that the learned features could be used to detect blood vessels from skin images. However, visualizing features is an implicit method to understand what the network does. Our SSAE network actually can also localize the vessel so that doctors could examine the location. The system used a patch strategy with 32 by 32 pixel patches that a skin lesion is divided into many small patches. Each patch is examined whether there is an absence or presence of vasculature based on the SSAE features. At the end, the location of the patches are identified and indicated by green patches. Recently, I'm interested in another method, the attention maps, for localizing the focus of the classification system. In this technique, a heat map is used to identify the region of the focus. There are a number of such techniques. One of them is called GradCam. When a picture, say a picture of a dog and a cat, is input to a network, GradCam could localize the dog with heat map when the classification result is a dog. Similarly, the highlight is on the cat if that is the answer. GradCam is a processing method without altering the network, so the network could run as is. When the classification result is reached, GradCam just backpropagates to the activation map based on the weighted gradients of the result and calculate the neuron weights. Then a cross heat map is generated, highlighting the area of attention. Potentially, the technique can be combined with other localization methods. Currently, we are evaluating the usage of the technique. Clinical knowledge. Dermatologists has been studying skin cancer for a long time and they have accumulated a large knowledge. Could we make use of the knowledge? Also, the doctors will find the application of familiar knowledge easier to accept. For example, vasculature is the key diagnosis features for melanoma and basal cell carcinoma. Doctors are familiar with this biomarker. Therefore, we developed an SSAE network to detect and localize the vasculature from skin images. Then the technique was applied to BCC classification. We believe such approach would enhance doctors' interest and confidence in applying the system. In a study of almost 1,200 dermoscopic images of BCC and non-BCC, the latter include sebaceous hypoplasia, seborrheic keratosis, and dysplastic nevi. We used 300 images to learn the SSAE features for the vasculature detection. The remaining almost 900 images for BCC classification. The study results showed that the BCC detection accuracy was 85% with sensitivity 75% and specificity 89%. This is a very good result for identify BCC when only one feature was used. Another example is the 7-point checklist demoscopic algorithm for melanoma detection. This algorithm examines 3 major criteria, which are atypical pigment network, blue-whitish veil, and atypical vessel pattern, and 4 minor criteria of irregular streaks, irregular pigmentation, irregular dots and globule, and regression structure. Any presence of the major criteria is given 2 points, while the minor criterion is given 1 point. The total of 3 or more points will mark the lesion as a suspicious melanoma. This is a well-known algorithm, known by all dermatologists. Could we make use of this kind of clinical knowledge on top of the deep features? It is encouraging that recently there are works on building a classifier based on the 7-point checklist. I would like to mention two papers. One of them is an IEEE paper on building a multitask, multimodal neural nets. Another one is a conference paper from a European workshop. Recently, a PhD student of mine, Yuhang Wang, is working on this similar problem, and I can tell you more detail next time. Another point I want to talk about is to use extra information to help the classification accuracy. We have been playing a handicap game for a long time that use skin images as the sole information source. When a doctor diagnoses a skin lesion, he or she will make use much more information, including what we call the clinical information, such as age, sex, and lesion site. I am very happy to notice that ISEE had realized the situation. In the task 2 of the 2019 challenge, metadata were included. Then in this year challenge, the term metadata is changed to contextual information. When we work on the BCC classification problem, as I mentioned earlier in the talk, we also include patient information, which is lesion location, lesion size, its elevation status, patient age, and gender. Our results show that patient information is very informative. By itself, it achieved a ROC accuracy of 0.76. Our SSAE network of detecting vasculature had an area under the curve of 0.85. Combining both of them pushed the area under the curve to 0.91. In my opinion, another way to improve the diagnostic accuracy is to combine different modalities, such as combining both clinical and dermoscopic images. Clinical image shows skin surface features, while dermoscopic image show the internal skin structure. Hopefully, by fusing the two modalities, we could gain more power to make a diagnosis. In the 2017 MICCAI meeting, there is a paper on joint clinical and dermoscopic information in detecting deep saliency features. The paper, the IEEE paper, and the paper from an European workshop that I mentioned earlier also make use of the images from both clinical and dermoscopic images. All three papers find improved performance of using two modalities. We conducted a preliminary study with clinical and dermoscopic images and find that dermoscopy has more power to classify melanoma, but adding clinical image could improve the result by 5 to 10%. 5% is respected to the dermoscopic images and 10% for the clinical images. The improvement is in line with the three papers I mentioned here. Are there other modalities we could use? The answer is yes, and the list is long. Recently, there have been a rapid development in non-invasive in vivo skin imaging technology, such as refractance confocal microscopy, fluorescent microscopy, and multiphoton microscopy, just to name a few. Many of these techniques could visualize cellular level details. And here, I would like to talk about a new technology called Polarization Principle. It is because I have been working on this technique for a while, and the technique is somewhat related to dermoscopy. So what is polarization? Roughly speaking, polarization is the chamfering orientation of the electrons of a light beam. When the electrons are traveling in a coherent fashion, the light is polarized. When the electron travel in a random orientation, The light is called an unpolarized light. All of you might have used a polarizer before. For example, your sunglasses or the windshield of your car are polarizers. They allow light with certain polarization to pass through. By rejecting most of the randomly polarized light, we can see clearly without glare. So, you would say that is physics. What does it have to do with dermoscopy? Well, dermoscopy, particularly dry dermoscopy, use polarization principle. The light source of a dry dermoscopy is a polarized white light, usually generated by a LED light. The dermoscope has a polarized filter. When the filter is set to 90 degrees from the instant light, we will see the internal wheel. Similar as the ideas of removing glare from windshield. We could also get a surface view from a dermoscope by setting the device polarizer to the same direction as the instant light. The surface mode, however, is not used that often because most people want an internal view from dermoscopy. Now, how about polarization speckle image device? The device uses a laser as the input light source. Laser is coherent light and polarized. We can obtain the surface and internal view in a similar manner as the dermoscopy by adjusting the device polarizer direction. But because we use a laser light rather than a white light, we have another option. The internal view could be generated by using a long wavelength light source, such as red light. On the other hand, a surface view could be generated using a short wavelength light source using a blue light. But unfortunately now, we don't have a color image, but get an interference pattern instead. I am sure you all have used a laser pointer before. When you point the pointer to the projector screen, you will see a shimmering pattern that is called speckle. That is why the technique is called polarization speckle. Now we have to find a way to analyze the texture pattern. When a polarized light passes through or backscattered by an object, the light will lose its polarization. The process is called depolarization. We can determine the amount of depolarization, which is a function of image intensity. Then we can analyze the surface and the internal view generated by either using a short wavelength light or long wavelength light of the polarization speckle image. In a recent study of polarization speckle images, we classify melanoma and seborrheic keratosis using machine learning techniques such as support vector machine, k-nearest neighbor, and random forest. We noticed that the blue light data generate an excellent result. For example, random forest achieve an accuracy of 90%, while the other two methods both achieve an accuracy above 80%. But the result for the red light data is not as good. It is because the blue light data encode information of skin surface roughness. It is well known that seborrheic keratosis is a rough lesion, but melanoma is a smooth lesion. Dermoscopy with an internal wheel cannot be used to analyze skin surface roughness. Even with the surface mode of a dermoscope, would have a problem to detect skin surface roughness. It is because when light is directed perpendicularly onto the skin, such a way that the dermoscopy projects the light onto the skin, the resultant images do not show the surface roughness of the skin. However, using polarization speckle, we could now detect skin surface roughness. That is why the blue light data have an excellent power to separate melanoma and seborrheic keratosis. Well, you may ask whether we could extend the technique to classify cancers versus non-cancer. Well, the surface mode cannot achieve a good result, I would say. It is because it just say that by looking at the surface of the skin only, it is difficult to differentiate malignant versus benign in general. However, the internal mode of the polarization speckle using long wavelength of light source may be able to do that. In a recent preliminary analysis, we analyzed the red light data using a ResNet and obtained a very promising result for classifying cancers versus non-cancer. The accuracy is above 80%. The final goal of this line of study is to combine polarization speckle with dermoscopy and clinical images in order to improve the diagnostic accuracy. I would like to give a very short summary of the talk that I suggest methods to improve the computer-aided diagnosis system for melanoma detections. Finally, I would like to recognize my research team and sponsors. Thank you.